Stay tuned as we talk with medical professionals at the South Dakota State Medical Association's annual conference tonight on Call.
Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Welcome to On Call Television. We had the opportunity to visit with a number of people at the South Dakota State Medical Association meeting. During the annual event, we sat down with 15 doctors from across the state and with Barbara Smith, the CEO of the SDSMA. The topics vary from rural health care to health insurance, so sit back and enjoy these candid conversations.
We found that people who attend medical school and do rural training during that medical school educational process, and individuals who do their residencies in a smaller community in a state like South Dakota, they establish roots, and they meet someone, they start a family, they start to have roots in that state. And so we're looking at expanding the number of medical school student positions available, and also looking at the number of residency programs and residency slots that we have in South Dakota to do more training of our own. So we have that opportunity. I guess those are some of the factors that go into successful recruitment. Retention is a product of a community, and if an individual who has chosen to practice in a rural community feels part of the community, feels they're a leader within that community, makes some connections, they have a spouse who's also oriented to a rural setting, those are some key factors. And communities and current healthcare practitioners in a community can make a big difference on success of recruitment and retention. It starts, they say all healthcare is local, and it's true. That group of practitioners can identify those individuals who are in high school or college and have that potential to practice medicine or another healthcare profession, and make an investment in that student. And that's really how it starts, is to see it as part of your obligation is to assure the continuation of a healthy healthcare delivery system in your local area. South Dakota State Medical Association has just launched, actually this week, a Center for Physician Resources. And one of the areas that we'll be focusing on is quality skills training. And part of that will be how to serve as a team leader. And we're working on building strategic partnerships with different aspects of physician needs, personal, professional, and leadership, to focus on what are the needs physicians who are practicing currently have, and how can we develop partnerships with the experts in those different areas. The Medical Association is a professional organization. We represent our members, but we're not necessarily experts in how to prevent stress and burnout, how to improve quality skill training, how to be a team leader for a team of healthcare providers, but we can identify and connect with those partners who would then offer information, education, and support to physicians in those areas of greatest need. And the delivery system and functioning as a team is one of the areas that our membership identified through a survey we administered last year as one of their highest priority areas of interest. Is they just don't feel equipped to function in that way, and if we can provide some skill training for them, that's how we hope to make that transition. The state of South Dakota has also applied for a grant and has discussed with us the possibility of, if they receive that grant, to do that training on behalf of the medical home model. And so we're hopeful that we can marshal the resources together to really put some of that training program together.
Arrived in South Dakota to practice in 1976, right after I finished my residency in ophthalmology. At that time, there was a new clinic that was being formed in Sioux Falls called Central Plains Clinic. Got involved in the State Medical Association almost right away when I came back to South Dakota. I grew up in Sioux Falls, so I was very familiar with Sioux Falls and South Dakota. We really didn't have the system or health system like it exists today. In other words, physicians were almost standalone professionals. We had nurses that helped us, but we didn't have physician extenders. We didn't have all of the other help, if you will, in medical practice. 88, 89, we were faced with a dilemma in South Dakota, and that was about the height of the HMO movement in the United States. And we had several HMOs, a couple of them in California and one in Minnesota that was looking at South Dakota as a single HMO, which would mean that every single one of the physicians would work for one payer. And we didn't like that idea at all. So the State Medical Association, the executive committee got together, and we came up with an idea of starting our own HMO, which we were going to call Dakota Care. And I believe there were 5 of us that put our names on the line and guaranteed a note for $250,000, and we started Dakota Care on $250,000. And we did get some investors. We got enough money to guarantee the survival of the company. And the rest is all history. Dakota Care is still a very viable health insurance company, and I'm retired from practice, and I'm actually an associate medical director over at Dakota Care. So what goes around comes around.
I've always practiced in small communities. I started out in Webster, South Dakota, and I practiced there 10 years and then moved down the road to Milbank, and I've been there ever since. So I've always practiced in a small community. I think the things that are different when I came out of training back then and practicing in a small town, I felt like, well, you were kind of isolated too. Communication is the thing that's really different now. You were isolated, and you were it when you were on call for whatever came in the door, and you could and did take care of most everything, but it seemed like, transferring to Sioux Falls or another facility was more difficult and not done as much, and it just seemed more distant back then. And nowadays, it's a lot different. You can make one phone call and everything's set up, and you transfer a patient, and it gets done a lot more frequently. Partly that's because of patients' expectations for their care. If you don't have the latest and the biggest in technology, they want to go where it is. But even in our emergency room, you push the button on the wall and the camera comes on and the big screen, and you're talking to the doc in Sioux Falls, which is nice too. You get help, you get a second opinion, you get transfer arrangements if you need them, or It's a good thing. I think there's more teamwork. It's just getting harder to recruit docs to small communities. I mean, a lot of young docs coming out, they're concerned about their lifestyle and being on call, and you know, they're okay being employed. They just want to have a finite practice, a lot of them, and have time for their lives and their families. And you know, I can't blame them for that either. But there are ways to have it both ways, especially with things like I talked about, the being able to video with consultants and so on. I mean, you can have help. You don't have to be the Lone Ranger and do it all yourself.
You know, as a general internist and hospitalist for combined, you know, over 25 years, I delivered a lot of difficult news, had a lot of difficult conversations with patients, spent a lot of time at the bedside and people who were very sick and dying. It was always one of the greatest privileges of my career to be able to do that, to be allowed the opportunity the privilege to be with people in their most vulnerable moments, whether it was when they're receiving the bad news or when things were going badly, to be able to be in with patients and their families at these very difficult, emotional, tender moments was always a great privilege to me. But my health journey has taken me into those own spots myself, where I've over the last 10 years had to receive my own bad news and deal with my own decisions, difficult decisions about what I might or might not do. Without going into all the specifics of my past health, I was diagnosed with non-Hodgkin's lymphoma 10 years ago. I had a couple of relapses. I've had to have a high-dose chemotherapy and a stem cell transplant for that a few years ago. And then here, just within the last year, I was diagnosed with a complication of that treatment called myelodysplastic syndrome, which is a bone marrow pre-leukemia condition which precipitated the need for a donor stem cell transplant just 6 months ago. Well, I'd like to think that I've always been sensitive and tried to have display enough emotional intelligence with patients that I was working with to be able to resonate with them and where they were, because everybody deals with bad news differently. Some are stoic, some highly emotional, some wall it off, some want great detail, and you have to perceive that. Of course, I've had my own reactions and worked with my own family has had their own reactions, and so I've had to see that mirrored back to me. Unfortunately, most of those experiences with the providers I've had have been very positive, and that oftentimes it isn't just, it is much more than the news. It is much more than the facts. It's being able to connect, you know, at a very human level, because we're all exposing our the most vulnerable thing about us, which is we're all going to die. That's what, you know, one of the things that binds us together in the human race. And so we're sharing something very deep and special.
One of the big changes that we've seen recently is that we now can see Medicare patients for wellness visits, which seems like a fairly small change, but it's pretty amazing to have people come in. They've always got specific problems, but we are charged with looking for other issues, and we've discovered many people with low thyroid or diseases that were totally undiagnosed and that they would have never come in for. So I think this has really increased the health of the Medicare population, and it's really the whole purpose of prevention, trying to find disease before they become a major problem. Many diseases are impacted by lifestyles. I'm very much into tobacco control, and it gives us great opportunity to interact with patients about their smoking, and obesity is the other major thing. But we've been able to slowly, over the last many years, really get the smoking rate in South Dakota down. It's about as low as it's ever been in the state. So I think that's going to have huge payments over the years. Mainly just talking about it. It's amazing how many people will seriously think about quitting when their doctor says, "Joe, I want you to quit smoking." That's a powerful tool. And before, oftentimes people came in for a cough or runny nose, and we either too tired or too busy or too this or that to actually stop and spend time about it. Medicare now really encourages us to engage people on these issues. Decreasing activity like obesity and tobacco use that interacting with a doctor can often impact. So actually I'm very excited about it. It's going to be tiring. Well, there's an exciting new opportunity coming up in the National Congress. The President has suggested, and there's been a Senate bill introduced to increase the federal tax on tobacco by 94 cents. The one thing that gets people to quit smoking is the increase in cost. And they estimate that millions of people will consider quitting smoking if this is passed. I'm really hoping that this won't be, quotes, no new taxes mentality, because this is going to go entirely to public health and to education. So I'm hoping that that's going to move forward and be a reality in the very near future. We're spending billions on the diseases caused by smoking. If we can get just a small percentage of people to quit, what an amazing blow, positive blow for public health. We all know that it's a bad addiction. There's no argument about the science anymore. It's just moving from being a user to being a past user, like so many of us are.
Back 27 years ago, I was managing death, so to speak. I mean, I had patients that were end of life, and what limited resources we had. I mean, we didn't have much then. I mean, we had some orals, we had some IV things. We really didn't have hospice per se. That came around probably late 80s, early 90s. Didn't really have that. Did a lot of in the hospital managing. And back in those days, there was not a lot to do for some of the cancers. I mean, the drugs weren't there, the biologicals weren't there, the orals weren't there. You did what you could, and then you just kind of kept them comfortable as best you can with what limited resources you had. Everything's evolved since then. And we've gone from basically you're in the hospital, it was really a heroic measure to take someone home and do something at home. Keep in mind they're going to be uncomfortable, but they're at home. To nowadays we can send people home, and we can manage things, and we can keep them comfortable. We can transition them. And we can transition families a lot better too. I mean, it's been 27 years, but things have progressed to the point right now where you're really not hesitant to send someone home. Back 27 years ago, you're hesitant to send someone home because it wasn't going to be a good outcome, so to speak, from a comfort standpoint, from a quality of life standpoint, for both the patient and for the family watching what's going on. I mean, a lot of bad feelings about how so-and-so died back in the 80s versus I don't want anybody else to go through that ever again, and it's not going to happen again. So everything has moved along and it's better. I mean, we have transdermal medications now. We've figured out what you can give and how you can give other medications that benefit. And there are more adjuncts now. There are other medications you give which help with, I'll say numbness in fingers and toes, appetite stimulation. There are other things we can do now. So everything's pretty much become a progressive benefit for the patient and the family, because the family's got to sit there and watch all this going on. So everything's better. There's always the patients swore they'd never pass away in the hospital. They want to pass away at home, and then there's some people don't want them to be at home. They want to be, it's a personal thing, deciding where people want to go when the end comes. I can think of one time where the patient told me, this is what I want to do. The husband came walking and said, no, that's wrong. And basically I said, I'm sorry, your wife just told me this is what she wanted. Well, she doesn't know what she's saying, and we went through that discussion. And eventually I said, well, this is her wish. I have to go with her wish, not yours. And he became very upset, wouldn't talk to me. I mean, she passed away about 10 days later, but he was so upset with the decision that she made and I allowed her to make, and wouldn't go along with his wishes. I'm trying to help. That's what I'm trying to do, is help them and manage them through all these problems. I'm the one that's responsible, and part of my responsibility is being upfront with them, trying to get in a position where they're going to be comfortable, trying to do whatever I can with their problem, but part of the responsibility is honoring their wishes. And this is part of being responsible. You go with what they want.
We
we've really been working at kind of bringing it back to more, back to the mother-baby dyad and the family and the experience, and integrating something called skin to skin. So really trying to get the baby with mom to help that transition, and taking kind of some of the procedural hospital anesthetic things out that actually, when we look at the research that's out there, don't improve outcomes, but actually might worsen outcomes long term. When births were at home, there were some increased in infection, some increased in maternal death and infant death. There was an initial improvement when we went into the hospital, but like I mentioned, that being a procedure, there's loss of some of the, I think, experience. And so, interestingly, you'd think things would get better and better, but actually something that's kind of transitioned and happened is there's kind of been a shift where we were getting better, there were improved outcomes for a long time, but now we're actually getting babies that are being born earlier, and they are surviving, but then there's some sickness that can come along with that, or morbidity. And so it's an interesting kind of balance of, we want to have healthy, happy babies and moms. That's always the goal. The electronic monitoring that we actually do in the hospital, it's been shown to improve, or I don't know if improve would be the right word, but increase cesarean rates. But it has a very high false positive rate. So the monitors can look very scary or make us concerned for baby's health. And then we have a baby come out that's screaming and happy and healthy. I think the thing is really having good prenatal care, consistent prenatal care. That's one of the things that has been shown to improve overall health outcomes. And there's a new interesting concept since the mid-90s of kind of actually group prenatal care, which is exciting to me because it actually, among decreasing postpartum depression rates and improving breastfeeding rates, has actually decreased preterm deliveries, which, again, we've been looking for things that do this, and so there's something magical about it, and Yale University is actually doing the research on it to try to figure it all out, why it works, but it's exciting.
Hospice is a program that helps to support terminally ill patients and their caregivers and families as that person reaches the end of their life. In our country, I think the program and the whole concept got a huge lift actually from coverage through a Medicare program of hospice. One of the things really that the government did right, I think, is have a hospice benefit. I think hospice programs have been somewhat successful, although not as much as we would like, in helping people to die where they and their families desire to have them die. So historically, people have died in hospital settings or nursing home settings, but I think a lot more now we're able to keep people in their home settings and with their families and caregivers. Again, the percentages aren't what we want to see with that, but a lot of people really prefer to be in their home. We certainly have hospice services available in a lot of the larger communities. Where we really lack is probably in the real rural areas. So, we go out probably about a 40-mile radius from where our program is. I've had many people in smaller towns that aren't in that radius or anybody else's radius, and certainly people that live in the countryside. This is a benefit that they should have access to as well. It's logistically very difficult to staff that and have people on call constantly to go out and deal with issues. But I think we have to try to find a way to better that, so provide that service. I think as our population ages, we have more chronic and life-threatening diseases. I think people are going to become a lot more aware of choices they have as their chronic illnesses progress. There's another area that is developing known as palliative care, which has a lot of the same concepts and goals as hospice does, but that can be initiated a lot earlier when a person is still being more aggressive with the management and the treatment. Somebody with cancer, for example, who also has a lot of pain and a lot of family problems, etc., that are related to their illness and they need the support. Palliative care can come in and do that, and yet the person can aggressively pursue chemotherapy or radiation, hoping for a cure. So I think we'll start to see more of a palliative care approach And that blends right into a hospice approach as a person reaches the end of life.
Well, the classic principles of ethics that we talk about in medicine are beneficence, which is doing good, non-maleficence, which means do no harm, autonomy, which means the patient has rights to decide about his own health care, and justice, which looks at how we spend our healthcare resources, whether they're the provider's time or most classically we think of money. And that becomes important when you have limited supplies. Another important value is truth-telling, trying to look at the facts. But a lot of times what we need is wisdom, knowing what to do with the knowledge. We may have treatments that can be tried, but for a given patient, are those the right treatments? First of all, will it work for that person? Secondly, is the burden of the treatment going to be so much that he would be worse off? For example, many of my older patients have a lot of comorbid conditions. I take care of patients in nursing homes. Quite a few of them have advanced dementia, and we sometimes struggle as providers and family members. Should we put them in the hospital? At the nursing home, the staff knows them. They kind of know the staff. If they've been there a couple of years, they may not know their names, but they know there's somebody familiar. They know the routines. You put them in the hospital where everybody's a stranger. They often end up tied down or given sedatives, then they don't eat or drink, and they come back and they're worse off than if we'd have treated them in the nursing home. Well, I think there's a mixture of viewpoints. There are still people who feel that we should do everything as long as the patient is still breathing and maybe even beyond. There are other people who don't want anything. And then there are a lot of people who are willing to try something as long as there's a potential for a good outcome. But everybody's got their own idea of what the outcome is. So that's why communication is so important. Healthcare providers need to be talking with patients and their families what you can expect from this treatment, not just come in and sit in a room for an hour and get stuff pumped into your veins, but is this stuff that we hope will shrink your cancer also going to make you feel sick as a dog for a couple of weeks, and you may end up in the hospital with an infection? And oh, by the way, it won't cure your cancer, but it may give you a couple months of extra life. Those are the kinds of discussions that it's tough to have with patients, but you need to think about what they need to know to make a good decision.
With healthcare reform, you know, they're looking at value treatment, and they're looking at outcomes. And with evidence-based medicine, it's been pretty well shown that palliative care gives a better outcome. And so that I know that both of the systems in South Dakota are developing, you know, palliative care programs, and are training staff into counseling patients and their families in palliative care. And I think over the next 5 years you'll see a big change in this state, because I think it's become, you know, pretty well thought that it should be the standard of care. When you have a patient diagnosed with a serious illness, you have a pretty good idea what the odds are of how this is all going to go. And I think from day one, you need to have a conference both with the patient, most importantly, and the family, and lay out the facts. And then kind of come with a game plan. You know, that, you know, we're going to, you know, treat this illness, and we're going to see how you respond to it. And if you respond to the therapy, which some people do, fine, we'll continue to aggressively treat you. But if it gets to the point where we can see that things aren't going well, then we're not going to quit taking care of you, and we're not going to give up on you, but we're going to switch our therapy to giving you the best quality of life that we can for the time that you have left. And I think that's the real key, is that you don't say, well, you used to see in the old movies, the doctor would say, well, there's nothing else I can do. Well, there's always something you can do, but it might not be aggressive chemotherapy or radiotherapy. It might be controlling symptoms and controlling pain and getting the patient into a living situation that they're happy with or most happy with. And I think that's what palliative care is all about.
One of the major drivers most recently for health system reform was recognition that there are so many citizens in the United States that are uninsured. So well before all the legislation hoopla started, the American Medical Association started a campaign called Voice for the Uninsured. And there were nearly 50 million citizens in this country that had no health insurance. And we as physicians know that patients without health insurance live sicker and die younger, simply because they don't have insurance. Because they wait longer to go see a doctor, and by the time they do go see them, their disease process is fairly advanced, and it's much more likely that they're going to succumb to their disease. So we believe that it was important to cover more Americans with health insurance. And so that was one of the major goals of the health system reform legislation that was passed in 2010, was to increase insurance for 32 million citizens in the country. So that's one big piece of what happened. There were many other components, obviously, in 2,500 pages of legislation. There's a lot of details in there. But one of the big things was get more people insured, get more of our patients so they have insurance coverage, which would hopefully help them be more preventative in their care and their behaviors. And so they'll hopefully prevent getting sick rather than wait until they get really sick. One part of the legislation in these accountable care organizations changes the dynamic of the responsibility for what in the system. And so when the accountable care organization is responsible for a group of patients and their well-being, the belief is that will lead to more work on the preventative side and less on the intervention side. Because we all believe and know that it's much more cost-effective to see prevention rather than intervention. By the time you intervene, it's much more expensive. So if the accountable care organizations can do that, they may well drive more resources toward the preventative side, and then that would hopefully save on the intervention side. Every day I'm looking for better ways to make sure my patients get the best possible care and that they are healthy rather than sick and repaired. I also want to make sure that the patient-doctor relationship is preserved. I'm very concerned about things where there's interventions into the exam room inappropriately from payers, lawyers, governments. And what I mean by that is if there's some sort of a legislative law passed about what I must say in my exam room or what I can't say in my exam room to my patients, I'm very worried about. There's a number of threatening pieces of legislation around the country about that kind of thing that say a doctor must say something or a doctor cannot say something in his exam room. And I think that's a very dangerous place to be with legislation. I think it's also dangerous for payers or lawyers to come into my exam room and say what I can and can't say as well. So I'm very, I think, jealously protective of the doctor-patient relationship that I think is the central part of our healthcare system today. So I'm very worried about that.
There's no question. I mean, what's driving all of this in the bottom line is the cost of healthcare and our national debt. I mean, there's no question, and the cost of healthcare is a major factor in driving the national debt. Saw some data just recently. The average yearly cost for a family in our area for their healthcare insurance and their out-of-pocket costs about $22,000 a year. So equal to a college education in a state-supported school, let's say. Well, how long is that sustainable? So clearly, we have to make some changes, and that is the challenge across the country, not only just for rural healthcare like where we're at. I think as an industry, healthcare, has we really haven't embraced principles that have made us extremely efficient. There's been a lot of redundancy, a lot of maybe unnecessary tests and so forth. And so, as a profession, I think we really need to address that. And so, I think that has started, and a part of that is now readdressing the model of how we care for people. South Dakota Medicaid, for example, is looking at and will deploy a health home model this summer across the state. It's a medical home type of model, and as we've visited with the state, their challenge is there's some 120,000 Medicaid patients that they try to get care for. And if you look at the sickest of the sick, if you tier them into 4 levels, tier 1 being not so sick, don't really need a lot of care, and you look at the sickest of the sick, and they're the patients that have maybe more than 10 medications and 10 diagnoses and 25 emergency room visits and 10 hospital visits and just a lot of issues. That's 5% of that population of Medicaid patients, and yet they're responsible for 85% of the state spend. And so we have to learn, and we have to treat those patients differently. And so I think across the country, the move that's happening to do that is the development of more of a team care approach, a medical home model, where you're just not relying on the physician or the physician and his nurse to provide for all the needs of that patient. And so now you surround that patient with a coordinated team that can address not only what meds they need for the day, but do they have access issues and being able just to get to the office? What's their home situation like? Can they afford their medication? Do they have behavioral health issues that we need to address? And so treating those patients in a different way to ultimately keep them out of the emergency room and keep them out of the hospital. And so that's the biggest challenge for us, I think, going forward. As you move down that tier, let's say to the tier 1, tier 2 people, you want to do the preventative things upstream so that they don't become tier 3 or become tier 4. And that's not going to happen to everyone, because we all have genetic dispositions to certain diseases, right? But the sooner that we can intervene, the better outcomes that we'll have, and hopefully less costly outcomes in the end.
When I was president of the State Medical Association, I was the first woman who had been president of the State Medical Association. There weren't nearly as many women physicians in practice as there are now, and I think that's changed the workforce significantly, and I think that's a good thing. I think that organized medicine is very important to the physicians everywhere, but to physicians here and to physicians across the country, so that we have some control in making policy and directing how healthcare is going to go, because I think we're the ones that know the right way and what's best for patients. So I just am very passionate about people being involved in that and paying attention to what's going on. Or at least we're moving towards a big change in how healthcare is delivered, because we have to figure out a way to do it more efficiently. And so the team approach, at least now, the thought is that's going to be the way to make it more efficient and more effective. So we'll get better quality at lower cost. That's what everybody's trying to get to. So, and ultimately, whatever physician is taking care of a patient, the health of that patient is where everybody's trying to get. We just have to figure out what's the best way for all of us to do it together to get there. And so I think it'll change, and you have to try something and see if it works, and if it doesn't work, then we'll do something different. We have things that bind us because we're all physicians, but we also have things that tend to try to push us apart because there are different issues. in what you believe or what you want to do or how you want to practice or, how those things are going to work. And so sometimes different segments of that group sort of push themselves away or get pushed away, or there's disagreements, but for the most part, it all comes back together again because ultimately we all have the same goal.
You have to remember that physicians of my generation were trained to be all by yourself. That's called training in the silo. You were presented material in a lecture, you went home at night, you studied it, you memorized it, you came back the next day all by yourself, you took the test, and then you started all over again. So we were trained to be all by ourselves. And then as soon as we were done with our formal medical training, and as soon as we were done with our postgraduate or residency training, then we were turned loose onto the marketplace and onto the patients and had to go figure out how to work in a team approach in a clinic with front office staff, with nursing, going to the hospital, making hospital rounds, working with other physicians. You made the transition from a student to a professional physician with no guidance on how to do that. Somebody just assumed that you did. And I think I made the transition okay. I've watched colleagues not make that transition okay. And I would think that patients probably have seen physicians who made the transition easy and physicians who didn't. What we have learned as medicine has evolved is that it is a team approach. You still need a captain of the ship, but you need to have a whole bunch of crew members that make that ship go through the seas just right. And that's how you have to look at what we're doing. None of us are out there all by ourselves. We always have a support team. The other thing that we have is access to up-to-date medical information to help us anytime we think we're in a situation where we really might not know what the answer could be. We don't have to guess, we can look it up. We can look it up online, on the computer, in the examining room with the patient sitting right there on her shoulder. And patients don't mind that at all. So the transition from having to know everything yourself to being able to work in a team is going to become easier over time as medical education changes. As the dean of the medical school told us this morning, there's a curriculum change going on that's going to actually teach teamwork from the beginning. That's going to be a change. Change is oftentimes hard to make happen. And there are a lot of individuals who find change difficult. There are a lot of individuals, and I put myself in that category, who welcome change. I don't mind it at all, as long as I am convinced that the change will be better. And people who make decisions above me have already said change is coming. And so rather than fight it, I'm going to do the best I can to help make it work. Well, I think we have to be able to show new young physicians the value of an active engagement in their professional organization. Somehow along the line, the importance of that has gotten lost. Those of us who've been through it need to know that we have to modify and alter our ways of approaching our young physicians to get them to understand the value of this organization. We can't just assume that they might look at it like we did. And those of us who've been here, those of us who've been leaders in the organization, we need that as our charge, to take back to the younger physicians and show them the value of the organization and, more importantly, the value of their participation in the organization. Exactly how we do that, I don't know. I think it's a one-on-one. You make friendships, you make contacts, you spend time, and those of us as senior physicians really do have more time to do that than when we were younger trying to build a practice. So I think it's incumbent upon us who've gone through to take what we know and help the new younger physicians recognize the value. They won't look at it like we did, and we have to understand that. But there is a value to what this organization stands for, and it's up to the new younger physicians to make sure that that continues. We have to remember, from our standpoint, and hopefully from theirs too, that if we have a strong advocacy organization for physicians in South Dakota, the best beneficiary of that are the patients. And since that's what we do, we exist for the betterment of our patients. We just have to make sure that we can understand and put those two concepts together. There's no way around that, and I think it's good. I don't find that threatening. I find it welcome. I think that the way that we take care of patients 20 years from now will be drastically different than we do today, much like it's drastically different than it was 20 years ago. Those things always change.
I think it's going to come about that the patient choice, the quality of life when it's nearing its end is real important, and we you know, I was in an era, and I'm sure many others too, where it just wasn't talked about, and it is a tough topic to talk about amongst physicians or when you deal with families. It's communication is a very important concept. It's taken me a long time, and I'm still learning through the process of how you deal with family members. You know, what is the way that you present this, so that they don't immediately think, well, you're giving up on grandma or whatever the case may be. And it's a challenging situation, especially when the relatives call from afar and wonder, you know, well, what's going on, and we all would do that. Certainly, it'd be the same way. And so that communication element is very vital to the making certain that these programs are held in good favor, and for the most part they are. We get, you know, the nurses again do most of the work and get the nice thank yous, and they become the same as we. You become very attached to those patients, and it's tough to see them go, and yet you want them to go in a peaceful and right way, and it's an interesting concept, and it's continuing to evolve. There's no, you know, where it's going is an interesting question, but it is being taught and more emphasized, and more, you know, they're wanting us to discuss with patients end-of-life issues before it becomes a crucial situation. The idea that you bring it up, and it's tough to do. You know, you're sitting there with healthy people, and you say, well, what would you want to do? You know, what are your thoughts if your situation changes and your prognosis is not good? How far do you want us to go? I mean, we still give people the right to say, you know, send me everywhere and do everything you want, but when you explain it carefully to them about the amount of time and effort and discomfort and travel, etc., that and looking at the real meaningful, you know, what are the chances that this process is going to get you better. When you sit down and have those type of conversations, usually you'll get an honest answer from most of them, that they're comfortable with the supportive care rather than doing quote unquote everything. But it's a change for those of us who've been in the profession for a long time to bring this up, but it's important to do so.
You know, when I came here in the early 80s, clearly the majority of the physicians, by far, you know, were independent practitioners, as I was. We made a transition in 1993, but I think statistically now about 70% of physicians within South Dakota are employed by another entity or one of the three main systems in South Dakota. Part of the challenge that we have as a rural healthcare system is that geographic diversity, and then the fact that you've got physicians, many of whom were independent in independent practices throughout the 4 or 5 state region, along with physicians who have never been in an independent model and have always been employed. And so I think part of the challenge for us is to pull that disparate group of people into a medical group that really has a common purpose and so forth. And so, yeah, I would say that we are fairly collaborative in terms of some of the things that have existed, you know, regionally or in an individual site. But in general, going forward, I think to be most efficient and to be consistent and to deliver on a consistent brand promise to our patients that we're going to give the most appropriate and best care wherever you're seen in our system, whether it's in a tertiary facility in one of our main regional facilities or if it's in a small rural care facility, that you'll receive the most appropriate and best care for your problem. And so in order to do that, yeah, I mean, you have to look at what are the clinical best practices, what can we agree upon. And so that speaks to the service line initiative, where we take, for example, behavioral health or emergency medicine, family practice or radiology, cancer, and bring those specialists who exist across our system together and say, we need for you to you know, set the tone and set the best practices that we think should exist across the system, and then and then help to make that happen. In the end, when a patient's in the room and the doctor comes and closes the door behind them, I don't think the patients are going to notice a significant difference in it. And when I talk to my colleagues across our system, I asked them that. Has it changed when you walk in the room? Because that's what's sacred to us as physicians, in terms of that taking care of someone from cradle to grave, let's say. So I don't think that part changes. I think what does change, though, is that the mode of payment from third-party payers, from the federal government and so forth. I mean, that's what's changing dramatically. So we're moving from that fee-for-service model that we all practiced in to more of a value-based system, in which, if you're not delivering good quality care to patients, and that's documented with data, then you're going to get decreased reimbursement. And I think that will present challenges to physicians who remain in especially smaller independent groups. The other challenge is we know that there's much more of a move to bundled payments for certain types of procedures. There's movement towards an accountable care organization type of mentality. In order to do that, you really need to be attached to a larger system, I think. And so I think, although there will be independent physicians, believe me, that will continue to remain independent, I think that number continues to shrink, and I think it becomes an increasing challenge, for physicians to remain independent.
When I started practice in 1982, I've always liked to teach, and the Association for Practitioners in Infection Control asked me to give a talk on this new disease, AIDS, which was named in '82. So I did a Medline search and gave this talk, and somebody else wanted it, so I gave it a few times. And when a patient came back from Philadelphia to Wichita with Kaposi sarcoma and an AIDS diagnosis, he asked around who was the AIDS doctor. They all gave him my name, and I figured I could do it as well as anybody, plus the rest of the community was extremely grateful that I wanted to, because it was, as you recall, it was horrible how people were treated, and there was so much fear and hysteria mongering. So I've always tried to take care of the underrepresented and the people who need care the most, and this niche just sort of opened up for me. Well, we talk about epidemics, and that's the term most people use, but actually HIV was an endemic, and it was one of those things, the reason it became so prominent all at once is that it got into the population slowly. It's got a 10, 12, 15-year incubation period where people can be infected and not get sick, which is why we suddenly in the late 70s, early 80s started seeing all of these gay men, San Francisco, LA, New York, suddenly get sick. They didn't all catch it right then. They had been catching it all along, and then suddenly sort of popped up, and then we really saw the iceberg effect in terms of how many people were truly infected. So it seemed epidemic because it popped up all at once, but it was truly an endemic that had gotten into the population over time. Currently, it's still an issue. A lot of people think it's gone away because we do have treatment. You don't hear as much about it. It's not the ultimate death sentence, but we still have 52,000 people in the U.S. who get it every year. Our prevalence goes up all the time because we've reduced mortality by 80%. So anytime you decrease mortality but still have an incidence rate like that, your prevalence just continues to go up, which is what's happening. So a very small percentage of people with HIV actually die of AIDS. They die of other things, of course, because they're getting older, but we have such successful treatments. If people really take their drugs on a routine basis, they don't have to get sick and die of HIV. Now, most of the people that die of it are still those people who are not yet recognized. I lost a 35-year-old last month, but he was a very late diagnosis, came in with a CD4 count of 1, which is essentially no immune system, had been sick quite a while, and nobody thought about it. And he died of pneumocystis pneumonia because we just couldn't get a hold of it. So that's one of the reasons people like me are so passionate about physicians, clinicians, following the guidelines, which say standard of care is to test everybody 13 to 65 at least once. Just know your status. It's like colonoscopy. You're supposed to have one after the age of 50. That's standard of care. So I've been continuing to try and get clinicians and patients to expect that they should be tested at least once, just to know.
Thank you for tuning in this week. I hope that you found our visits with the doctors at the South Dakota Medical Association interesting and enlightening. Join us again next week when we'll talk about Obamacare. And until then, stay healthy out there, people.
Funding for On-Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubak and the Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.